Hello, I'm Dr. John Kruse, and welcome to today's question and answer hour, where I will try to answer questions about the video released this past week about ADHD topics in general and more broadly about mental health. Cupcake's here with me. He turns 15 this week, and there are some email questions I'll try to answer as well. So I will summarize the video in a minute or two and then jump into the questions, as I see there's already a few of them. So the video was on a research group that has found 3 different biotypes or biomarkers for separating out groups of individuals with ADHD. Most studies up until now have used the ADHD diagnoses for the subtypes or the presentations, as someone correctly said they are called now, of ADHD. Currently DSM says that there is an inattentive type of ADHD, a hyperactive impulsive type of ADHD, and then a combined type. And most studies find the combined type is actually the most common or variety. And then people have attempted to look at, are there correlations, neurochemical markers, brain activation markers, EEG, something that help us separate out those groups and or help differentiate ADHD from other conditions, and haven't come up with much success. The recent study sort of took a different approach. So they looked at brain scans from more than 1,000 kids, about 2/3, I think, who had been diagnosed with ADHD, another group who did not have ADHD, and then did sophisticated analysis looking at each area of the brain and seeing how well each tiny little area connected with other areas in terms of the efficiency of connections, the number of connections, and whether the connections were mostly local or long distance. And then use statistical measures to evaluate areas of the brain that were aberrantly connected, and aberrantly means at least 2 standard deviations from the normal pattern of connectivity for that node in the brain, and then made a composite picture of what nodes were being aberrant, and found that they were clustered into 3 overall patterns of strange wiring. They were actually roughly equal patterns. They called them biotypes 1, 2, and 3. And unfortunately, they sort of refer in their paper to, I might be mixing up the numbers here. So biotype 1 was, in terms of symptoms, had lots of emotional dysregulation, as well as fairly severe both inattentive and hyperactive symptoms. Type 2 had more hyperactive impulsive symptoms than inattentive, and type 3 had stronger inattentive symptoms. So at the surface, it looks like there might be some mapping onto our current categorization of ADHD, but actually on closer inspection, that wasn't at all the case. It suggests that our current presentations of ADHD are not tracking what's the underlying biology at all. So for example, the biotype 1 was about roughly equally composed of individuals who had combined type and who had inattentive type. So their biotypes probably need better labeling, but again, there are 3 distinct biotypes. It was a well-conducted study, a large sample size, done at 6 different areas, and then they replicated this and got the same findings with a completely separate pool of children from 4 different university settings. So this does not also tell us how well these biomarkers help distinguish ADHD from adjacent conditions like slow cognitive tempo or autism spectrum problems, but it's exciting research, and it's highly likely that much more biomarker research will go in this direction. And hopefully, if this is validated and upheld, it will, we won't just have to do brain scans, but there are probably biochemical and other markers that track with these separate groups. So happy to talk more about that. I do have 2 email questions. I'll answer Dennis's first question first. So Dennis's first question, hello, is physiologically speaking, is it true that the ADHD brain resembles a sleep-deprived neurotypical brain? So what I would say is that what we can say most strongly is that behaviorally and subjectively, in terms of the feelings and performance of the brain, um, the, the what the brain can produce or do in a sleep deprived state shows remarkable overlap with ADHD. And that's not just impairment in directing attention, sustaining attention, but working memory. Impulsivity is higher, emotional regulation is poorer. So we have the whole suite of executive function issues are affected by acute sleep deprivation and by chronic sleep deprivation. So there's several studies looking at people with sleep apnea, and some people with sleep apnea present as having ADHD. And there's a few studies in children and in adults where, in a number of cases, effective treatment of sleep apnea completely reverses these ADHD-like presentations. So I'm going to jump to Ruth in Australia, had 2 email questions. So I'll get to them and then jump back to the other questions here. So one of Ruth's questions was regarding the talk on the effect of stimulants on bone growth and questioning how much of that pertained to tooth growth as well, particularly given that since for many people stimulants cause drier mouth, decreased salivation, and that can affect the growth of bacteria in the mouth and increase the risk for cavities and tooth destruction is particularly important. And to my knowledge, I mean, the tooth tissue is a different tissue than bone. It grows differently and is subjected to different forces and factors. So, I mean, but what's important is that the jaw that the tooth is sitting in, the osteoblasts and clasts and osteocytes there, are subject to the same forces as stimulants. So bone osteopenia and osteoporosis in the jaw are theoretically some small but real risk for some people with taking stimulants chronically. So that may compound, again, the effects on salivation and microbiome in the mouth to impinge on tooth dental healthiness. And then Ruth had a separate question on the DSM, changes in DSM talk. I mentioned the research domain criteria. So that's several years ago, the National Institutes of Mental Health decided that we needed to be studying the brain more systematically and not along the lines of the DSM diseases, like studying schizophrenia, but studying what are the functions the brain does, how can we map those out in terms of anatomy, physiology, neurochemistry, and I'm in the middle of, sorry. So what are the 6 domains? She mentioned that I only mentioned 5 of the 6 domains. So one of the domains is arousal, negative valence, which is not just negative emotions like fear and anxiety and sadness, but also retreating or withdrawing from activities, positive valence, which is both joy and engaging, sensory motor functions, cognitive functions, and social functions are the 6. So I'm not sure which one I left out or whether I lumped positive valence and negative valence together. So that's their framework for trying to study the brain and hopefully leading to findings along this recent biotype research that would um, help further our field of mental health. So jumping over to Dennis's next question, and that is, does addiction liability depend on the drug? For example, I heard that, so Cupcake needs to go walk. So that's not a masked kidnapper, that's my husband. Does addictionability depend on the drug? For example, I heard that some drugs like cocaine are universally addicting, whereas heroin addiction requires a genetic predisposition. I'm not aware of any so addiction liability does depend on the drug. There are certain drugs, lots of drugs, which don't seem to have much liability for addiction. Prozac, even though some people say people get addicted to it, people do not crave Prozac. People do not start abandoning other activities in their life to use or score Prozac. Now, do people, some have withdrawal if they stop certain drugs? Yes. And again, withdrawal is a component of addiction, but not all of what addiction is about. So absolutely, addiction liability does depend on the drug. And animal models are usually used. So it's how much, putting rats in a cage and comparing how often they press a lever to get reinforcement, to get hits of cocaine, other things. I mean, certain things which are addictive in humans are actually aversive to rodents. So alcohol, you have to train them to like before they can become addicted to it. But whether some drugs are, so the drug has part of the role, but there's certainly a huge variability among humans, and some of that we know and have identified specific genetic factors control it. So I would not claim a drug is universally addictive. There are some people who can take cocaine and use it sparingly or appropriately for them and don't run into problems. And there are certainly many other people who use cocaine and develop problems with it. There's certainly evidence among the stimulant world that methamphetamine is more likely, people are more likely to wind up abusing it and becoming addicted to it than to amphetamine or to methylphenidate. So again, the first part I agree with, that the drug addiction liability does vary depending on the properties of the drug. But I'm not as convinced in the second part that cocaine is universally addicting. I mean, I don't know of anything that's universally addicting. So that's where I would leave that. Hello, Dylan. So Dylan asks, I have an opinion on compounded esketamine nasal spray. Do I see ketamine as something that requires clinical supervision? Can patients take it safely at home? So when esketamine was first approved, and still now in the US, only certain doctors can prescribe it, and supposedly they are administering it in their office under direct supervision. And they have to have the facility to monitor blood pressure and to monitor the patient in a quiet, undisturbed place for, I think it's 2 hours after dosing. Within the first month of esketamine being available in San Francisco, I had patients or who other people who reported that they were being given esketamine for use at home. I have a patient right now who is working with an established esketamine practice, and from the very first one, or maybe the second dose, they did provide some instruction, but just gave it to him and told him to make sure that housemates or neighbors were with him for the hour or two after taking it. So the guidelines for it are being widely, some potential for fluctuations in blood pressure. There can be low blood pressure is a common response, but then there can be rebound increases in blood pressure, high blood pressure, spiking. That's very rarely a serious problem. More often, depending on the dosage, and many of these esketamine dosages are lower than people are using at ketamine injection clinics. So ketamine's antidepressant effect seems to be at a lower dose than the dose ketamine evokes hallucinogenic dissociative experiences, but up to a quarter of those hallucinatory dissociative experiences can be um, highly uncomfortable, triggering panic attacks. Something like 15 to 20% of people can have, again, severe anxiety. So, I mean, one thing with the esketamine nasal inhaler, it is a preset dose. So if you know what dose is safe for you, I'd say after the first few trials, maybe it's really isn't particularly risky to be using it in a non-medically supervised condition. There are also, some longer-term issues with esketamine, particularly bladder, um, urinary tract issues, and also the question, getting back to addiction and abuse, is whether some people become addicted to ketamine, and or whether some people have severe rebound into depression, excuse me, including suicidal depression once they stop it. I mean, that clearly happens anecdotally. How common it is, it's less clear. So, Tamu Atting, Tumauting, sorry if I'm butchering that name, asked, how would I approach reinducing stimulants in adult ADHD patient who previously did very well on them, but developed panic attacks specifically around onset after major stress event? I mean, my approach would be to make sure that you've gone through some good CBT-based training for panic. And again, CBT for panic has been shown to change brain chemistry. Um, Panic is very amenable to CBT. So, I mean, it's essentially saying, yes, you're going to feel your heart beating harder or faster. You might feel sweaty. There might be other changes in your body. This is the reaction of the drug. This is not a danger. Um, this is different. This is maybe even uncomfortable, but it's not dangerous. And panic is when your brain jumps from this is different to, oh my God, this is dangerous. So I would strongly encourage good CBT practices beforehand. And then the general approach would be starting at substantially lower dose than you had before. And this is a case usually in the situation of sort of moving up aggressively on dose if you're not seeing much, but here, side effect of having had panic attacks triggered, I would go fairly slowly and make sure that it's tolerated. And messier doesn't always mean worse, but a messier is sort of introducing another agent. That there are many people who, even if they haven't had just full-blown panic, but have had high levels of anxiety, do well after a break, starting over on Guanfacine, which has a very low rate of triggering panic. And once they're stable on Guanfacine, then reintroducing the stimulant again at a low dose. So CBT, starting low, going slower, and possibly sticking guanfacine in ahead of time are all approaches to recapture the benefits of stimulant without re-triggering the panic. So Dylan asks, is it true that anything which chemically mimics or artificially enhances GABA will significantly increase dementia risk over time? Compounds that come to mind are benzodiazepines, gabapentinoids, phenelzine. So this isn't an area I've looked into in detail in the last year or two, and I believe it's real, but there are good epidemiologists and statisticians who are still not convinced that even the benzodiazepines have a high risk for causing dementia. So the association is absolutely clearly there. People who are using benzodiazepines, particularly for more than a year on a regular basis, it is associated with a higher risk of developing dementia. There's similar data more recently about the gabapentinoids. There's certainly another drug that acts on the GABA system is alcohol. Certainly alcohol abuse is associated with higher rates of dementia. But the question is whether this is a cause and effect result or whether it's a confounding factor. I mean, it could be that people whose brains are already compromised are more prone to anxiety, are more prone to substance abuse, and are more prone to taking these drugs or taking these drugs more regularly, and that's the true causative factor or closer to it than the substance itself. So, I mean, there's only a weak amount of research that suggests bigger doses are associated more strongly with it, which you would expect, but some of this is not as much data as we would want, and particularly in this day and age where advanced computing processes can let us crunch hundreds of millions of patient health records, we should have better answers about, again, whether this is an association or whether these are clear cause and effect relationships. I would certainly try to avoid or minimize long-term benzodiazepine use. Again, the gabapentinoid data, so gabapentin, Neurontin, and Lyrica is less extensive. That's what I'd say we know at this time. Again, on the other hand, chronic high levels of anxiety are absolutely toxic to brains. So, and in terms of, there's also not the full benzodiazepines, but we call the Z drugs, the Ambien, Sonata, Lunesta, which work on one subset of the work more strongly on one benzodiazepine receptor than on both benzodiazepine receptors. There's weaker data than there is for the benzodiazepines, that those are also associated with dementia risk. But the, again, big confound there is that almost certainly part of the dementia process is disruptions of sleep that are interfering with good clearing of amyloid plaques and tau tangles in the brain. So again, whether poorer sleep is just a marker or confounding variable, or whether these drugs are actually contributing to the process is less clear. So thanks for the vote of confidence, Goosebumps. Thank you. I'm glad that this is helping people and educating people. So Dylan next is asking, do I have any treatment recommendations for someone who is experiencing anxious depression? I think that my depression is a result of long-term trauma and resulting burnout. Um, so my approach is always to push on as many different levels as possible. So, I mean, at the basic, that's a combining medication and talking therapies. So seldom does medication solve everything. What I would say is that although there's a myth out there that you should never use Wellbutrin in an anxious depression, that is not actually supported by much data. And my clinical experience is Wellbutrin can certainly be effective in anxious depression. So what I'm getting at is I'm not saying it's particularly best at that, and it's probably not one I would start at, but I also wouldn't avoid it. Um, Wellbutrin is one of the few antidepressants that doesn't treat anxiety disorders when they're separate from depression, but if the anxiety is an element of the depression. So, yeah, so I'm not giving anything specific, but I'd say sort of trauma focused psychotherapy in combination with medication is likely to be of some help. Um, so, Mr. Cupcake's back. Yes, he wasn't catnapping, which he might do. He was puppy napped. So, Tom, Moting, would I consider something like Guanfacine first to stabilize norepinephrine before reintroducing or straight to low dose stimulant exposure patient Bastava? So I think I addressed that. My approach is always to keep things simple, just to keep expenses down, to keep drug interactions less likely to run into problems, to decrease the likelihood of trips or need for trips to the pharmacy, possibility that one or the other drug will be out. So if you can do everything with one drug, that's my approach. On the other hand, if you get a better result from the combination of two and you're getting good results with minimal or no side effects, there's not a problem with being on two things. And again, guanfacine seems to work in some fundamentally different ways than the stimulants do. So the combination for some people is clearly going to be, for some people, better than the best you could do just on a stimulant. So thanks, Max, for providing the link to the video on CBT on panic attacks. And let's say the simple overview or reminder about CBT for panic is that the approach is really, really simple. It might seem I'm making it overly simplistic. It's amazingly simple. That doesn't mean it's easy, and you need to practice it a lot. So it's overly rehearsed in there when you need it, because part of what panic does is it um, causes activation or deactivation or changes in blood flow to different parts of your brain. So you are less able to think in the middle of the panic. You are responding, reacting. You're not thinking, and CBT depends on thinking. Mark says, I heard that calcium has a lot of functions in the brain. If consumed more calcium in my diet, will this benefit my brain? So calcium has, yes, benefits throughout the brain, and I'd say throughout the body. I mean, it's an essential ion that neurotransmitter release, all sorts of functions are dependent on it. Um, but more doesn't, I mean, one is it needs to be in a form and in a location that it's useful. And, yes, there are conditions where there are calcium deficits. More often we focus on brain or bone health than on brain health. Um, so I mean, simplistic approaches of just taking more of calcium is not going to always help people's brains. I'd say it's safe to say that would be a false claim. Now, if you have specific deficits or it's deficit in absorbing it or using it, then it's possible that calcium supplements may be of help, but I'd say it's seldom that that's going to be a major problem someone is dealing with. That's where I'll leave that one. Um, Cosmos Princess, yes. Is there data indicating that Strattera, in tandem with the stimulant, captures therapeutic benefits for both ADHD and anxiety? So, unfortunately, and I do have a video on combination medications, there are only a handful of studies. I mean, part of it is that often the two drugs are made by different pharmaceutical companies. They're getting approval funding for doing it, and there's so many possible combinations. Which ones would be most ideal to look at? And the bottom line is there's not a lot of rigorous random controlled studies looking at combinations. There's a few with Strattera and methylphenidate. Um, and whether, and the ones I'm aware of are mostly focused on looking at ADHD symptoms rather than anxiety or mood symptomatology. So I don't believe that we have a lot of rigorous data on that question, but I do think there's some clinical experience, not just mine, because I don't use a lot of Strattera, but with others, that suggests it can be helpful for anxiety or other aspects outside of direct ADHD. My own strong bias would, rather than be using Strattera, which itself has not had a, be to use duloxetine, Cymbalta, which has potent serotonin reuptake action. I am sure, and I know this is, to my knowledge, this has not been done. If you looked at comparing Strattera head to head with duloxetine, Cymbalta for anxiety, I would almost guarantee that you will get better results from Cymbalta. This is just using it alone, just in an anxiety situation. But that to me makes it a more desirable choice in the setting of someone with ADHD and anxiety. Um, and often I would start with Cymbalta before even adding on a stimulant and see to what extent we're helping with ADHD and anxiety spectrum issues. So something collector, P collector, I'm skipping some of the letters. Does a week or two hiatus from Adderall reset fully the tolerance, and are headaches and jaw pain normal? So I'll start with the second one first. And then, I mean, by definition, they're not normal unless you are having headaches and jaw pain every day, in which case you wouldn't have noticed that they're associated with Adderall. So, not normal. Are they moderately common side effects of stimulant medication? Yes, they are. And often they are signs that it may be a little too much, that you're causing, again, over activation of sympathetic nervous system. Um, Headaches, some people, that's a constant ongoing effect. Again, if I have patients where that's the issue, that the choice is usually back down. But headaches often are there in the first few weeks intermittently and then tend to go away. Jaw pain, and separate from jaw pain, tooth grinding, which the fancy name is bruxism, particularly at nighttime, again, can actually result in significant tooth damage from Adderall or other stimulants. So that's one, it might not just be nuisance pain, you may be actually doing damage. There's some people who mouth guards are a solution at night, but again, it may suggest decreasing the dose or trying something else. And I'm forgetting, but I'm believing that there's certain serotonin 1A agents like Buspar that have some experimental evidence can help with the tooth grinding, blocking it. So regarding whether a week or two off, does that reset tolerance? So my clinical experience, and I have a whole video on this, is that most individuals do not develop tolerance to the beneficial ADHD effects, ADHD symptom lowering effects of stimulants like Adderall. Some do, whether a week or so. One is that there are also honeymoon effects when people start a drug. There's also when the particularly because the stimulants not just help with ADHD effects, they have mood improving effects. So how someone interprets or views the collection of their symptoms. So yeah, so I mean, if it works better for you or you seem to appreciate the effects more after taking a week or two off, good. I'd say in terms of getting back to bone health, the one clear adverse effect, long-term effect from stimulants in children that seems to be benefited from taking drug vacations is the negative impact on height or growth, specifically height. And there it seems to be several weeks to months off during summertime that seem to diminish or eliminate the negative impact on height from these. And again, the overall effect in studies is less than 2 centimeters, so less than an inch. But again, that's longer than a few weeks seems to be necessary for escaping that effect. Narendra says type 1 most probably sir stimulants in Strattera failed, only clonidine available in India. What to do? Um, so if clonidine is available, that's certainly worth trying for ADHD. Um, again, that I'd be surprised, but I don't know that clonidine's available and guanfacine isn't. So again, in the US, the form of guanfacine for ADHD that's specifically manufactured is intuitive, which is a slow release, but there is numerous studies showing immediate release guanfacine works as well as extended release, probably less daytime sedation in my experience. Um, so the big warning is that stimulants tend to work quickly, as does Strattera if you can get to an effective dose. And clonidine or guanfacine, if they're going to work, tend to take 2, 3, 4 weeks before you see an effect. So it's a more gradual, subtle onset. And I'm strongly favor guanfacine over clonidine because clonidine has a well-known risk of, so both of these initially are antihypertensives. And clonidine is, well, as there is a strong association with abruptly stopping or missing a single dose causing rebound excessive hypertension, really big spikes, not just the absence of what it was doing, but sending it up to 180, 200. Guanfacine, it's certainly a possibility, but studies that have specifically looked for it, it's much less likely. And given that ADHD predisposes people to forgetting a dose or not filling it in time and running out on a medication, that's why I favor guanfacine. And they may have subtle differences as well, in addition to their alpha adrenergic action. So Dennis is suggesting methylphenidate might be an option in India. So I think Narendra mentioned that stimulants didn't work. So even if methylphenidate's available, it may not be helpful to them. Hello, Vandy. Yeah, so okay, so you're ahead of me. I'm glad you're finding the videos helpful. Again, feel free to share them with your therapist, with your other people you know who have ADHD, anyone who may benefit. We continue to slowly grow, so that's gratifying, but there's clearly at least 10 or 12 other people out there in the world with ADHD who would benefit. Um, so Watson, Walter, alternative. Why do some ADHD patients feel worse in the morning during the wake up transition, and how do you smooth that out? So, one is that there's strong evidence that different chronotypes, so different propensities, who's a morning person, who's an evening person, are under strong genetic influence. I mean, that there's, as with everything, there can be training and practice effects as well. But so part of it is that many people with ADHD biologically, genetically, are less likely to be alert awake in the morning. Secondarily, if they've slept poorly or they got to sleep late, so there's also a propensity towards sleep delay. So relative to the general population, they're more ideally situated to be functioning again later in the day and not early morning, and yet the world demands they be ready and early in the morning. Um, so, what are some of the strategies for dealing with that? One is, and I don't make specific I don't get endorsements. I'm not getting paid by anyone, but Jornay, which is a form of methylphenidate that it's a brand name only right now that people take at bedtime and designed to not release any drug at all, much less than 1% of it for the first 10 hours, and then starts releasing drug. That is a good option for many people because if you time it correctly, if you take the dose in the evening correctly, then it is working when you get up, and that helps counter some of that morning transition, grogginess out of it. Um, Another approach that I frequently have found helpful with patients is if your wake up time is 9 o'clock, set your alarm for 7, take your stimulant medication then. Most people with ADHD have little trouble going back to sleep, but then when they wake up for real at 9, the medication is absorbed and active and working for them. I'd say other than trying to regulate sleep bedtime, and again, it's being consistent because the circadian clock is an important factor regulating sleep. Um, s- it's not just the duration of, you don't just need the same duration, you need to try to wake up and go to bed at the same time. There may be other behavioral approaches to um, set out your task, what you need. In the old days when most people left their houses to go to work or school rather than staying at home, setting out your what you need, whether it's packing your lunch, getting your books ready, getting your coat and clothes put out the night before, that helps some people with ADHD. So taking advantage of when you are more functional the night before than where you are in the morning, and or scheduling or putting fewer demands. Another almost counterintuitive one is putting in exercise when it may be hardest to do or start. But if you can, but you usually don't need to be thinking intensively during exercise. And for many people with ADHD and otherwise, exercise is a good way to sharpen their executive functions and be more alert and aroused for the day. So thanks, Max, for providing the link to the video on tolerance to stimulants. And I think it's Giselle here. The moment I started taking my meds on the weekends, my tolerance soared. Um, so again, there's lots of individual variation, and I am a big fan of figuring out what works for you and doing that regardless of my pronouncements or hopefully you can find a way to work with your doctor or other experts say. So Vandy is asking the broad question of what are my thoughts on immediate release Adderall versus extended release Adderall? Um, I have lots of thought. I mean, again, the bottom line is what works for you. So formerly, when I was starting people out, um, I'd say more people consistently or get a consistent response to immediate release than to extended release. And particularly with the proliferation of generics and extended release, again, the generics in the US have to have the exact same substance in close to the same amount, but there is some wiggle room on how quickly it gets in and the area delivered under the curve. And with stimulants, one of the things we know is how it's not just how much is sitting at the dopamine norepinephrine neurons, but how quickly that level is changing. Um, so the rate at which the drug gets in, not just how long it lasts, can have an effect on both benefits and apparent benefits. So I've worked with a number of people who were taking 5 milligrams of Adderall twice a day and switched to 10 milligrams of Adderall immediate release, switched to 10 milligrams of Adderall extended release, and said, Doc, you ordered a dummy pill. This isn't doing any good. There's nothing in it, even though theoretically the pharmacokinetics and profile and delivery, should have been close to the same, but it wasn't close enough for them to feel the same way or get the same effects. So the immediate release, I guess I would say gives more consistent results. The downsides of the immediate release are the big one is much more likely withdrawal crashing when it wears out. So the stimulants that taper off slowly, and most of the extended release formulations do, are less likely to cause a crash in executive functions, are less likely to cause a crash in mood, are less likely to cause a crash in energy level. Not that they can't, but less likely to. So that to me is one of the huge advantages of the XR. The other big advantage is, particularly if you're likely to forget doses because you're ADHD, if you can take one dose in the morning that covers your whole day, or even if it's two in the morning that cover your whole day, or one early morning and one late morning, that for many people works more effectively than taking multiple dosages throughout the day of an immediate release form. There is a small, and I want to emphasize small. I mean, there's lots of speculation, there's lots of logic, there's a fair amount of basic science that suggests that maybe the extended release formulations have a lower risk for addiction, whether tolerance is difference between one or the other. I mean, the claims, the claims are more extensive and louder than I would say the data to support it, but it's possible that there are advantages in terms of reduced risk of bad, uncommon side effects with the extended release. So Strattera is causing overstimulation and midnight awakening, also social anxiety, um, any leads. So one is, I am not a big fan of Strattera, as my video shows. It clearly works well for some people and great if you're one of those. So one is that most people need to go titrating up on it very, very slowly because it tends to have lots of side effects. So it may be as simple as going back to the lowest dose that was tolerable and staying there for at least a few weeks before it's certainly tolerable. So the bigger principle is often drugs that are overstimulating and intolerable when someone starts initially, and this is true not just with stimulants, but SSRIs and others. If you go back and start more slowly and go more gradually, many of the side effects people become tolerant to. So that may be one option. If duloxetine or another SNRI is available, I would say this again, which tend to be more potent and helpful for anxiety, including social anxiety. It may be a better match to try an SNRI than try Strattera. And again, that duloxetine has norepinephrine reuptake action as potent as Strattera does, so it should theoretically be as potent and effective at the ADHD end of things. Um, so Vandy is praising the rest of you for good questions. One of my weaknesses as a therapist is I'm not a particularly good cheerleader. So yes, I'm glad lots of people are here and lots of people are asking good questions. And I'm seeing we have about 10 minutes, so I'll try to rush through the rest of them. Um, my melomaniac is 1 or 2 times a week sleeping after taking methylphenidate okay, as it helps sometimes for good sleep. I'd say if it, uh, to me, the biggest downside of napping during the day is the potential for decreasing this sleep factor, the other non-circadian factor determining the fatigue factor, and making it harder to sleep that night. So ideally, most people do best with a consolidated chunk of sleep at bedtime. But if it works for you to occasionally nap or take it after the methylphenidate and you're still sleeping well at night, then I'm not hearing a problem with that. Um, so Giselle asks if I can take a nap after 45 milligrams of Zenzendi, is that ODD? And I'm blanking on Zenzendi because so I'm looking it up quickly, I hope, is a form of dextroamphetamine. Does that mean I have ODD? And ODD I'm not sure that's oppositional defiant disorder in children. So I don't think that's what you're referring to. Some people with ADHD do sleep right after taking stimulants. That's not particularly strange. And I wouldn't focus on the dose that much. That's a robust dose. So a couple things. One is many people with ADHD are sleep deprived chronically. If you're sleep deprived, then anything that helps make sleep possible sleep will occur. Two is, even in the absence of sleep deprivation, many people with ADHD have a hard time settling their brain and getting it into a parasympathetic state. And for many people with ADHD, stimulants are calming and helping with organization, and that helps them shut off their thoughts and fall asleep. So that's what I would say there. So if cyclic sighing doesn't work, what can I do to fall asleep? So one is that so a couple things. My own answer with cyclic sighing is often I do it and it feels like it isn't doing anything. And then almost always within a few minutes or moments after 5 minutes of it, I've fallen asleep. So one of the things we know with cognitive behavioral approaches is that telling yourself something doesn't work is likely to help make it not work. So I would try to be more neutral in terms of saying, I'm not seeing that it's working, but I can feel more comfortable and relaxed. So the second thing with cyclic sighing or other breathing or other approaches, most people can detect that they're at least feeling more relaxed or comfortable. And if you're not, it may be some slight tweaking of that approach. So with cyclic sighing, it may be trying to do a more extended exhalation. It might be trying to make sure that the exhalation is audible. It might be a completely different breathing technique, like box breathing, where you're counting out 4 for inhalation, hold, inhalation, hold, exhalation, hold, each of those for, 4 or 5 seconds. Um, for some people, it's um, relaxation imagery. That's not quite the visual imaging techniques that are helpful. Um, I'd say the other, making sure you're trying to sleep at the same time each night. There's good sleep hygiene tools. Stanford Sleep Research, which has been one of the world leading centers, I think has a good list on their website. But making sure you're sleeping at the same time, making sure your temperature is good, that it's quiet, that it's dark. Um, but again, trying to get into that parasympathetic state, because anything that's leaving you aroused is going to make it harder to sleep. Um, So again, I'll try to race through. So why are there so many people having difficulties with the efficacy of their Adderall since the pandemic? Lots of complaints about bad side effects as well. Again, some of these existed pre-pandemic, but it's possible that some of the shortages and was greater demand have brought in more companies that are less doing a good job with it. I don't know that there have been any detailed chemical analyses to find problems. So Narendra is his comprehension is also very dull. Heard acetylcholine is also involved in type 1 form. Any alpha GPC helps. I do have a video on acetylcholine, and I'll just sort of pass on that because I'm trying to get through things quickly and I don't have a quick or simple answer. So, can having part of the intestine remove affect absorption of amphetamines? It can. Most of the absorption, except Jornay or some other, Jornay is designed to traverse much of the small intestine. Most of it's happening fairly early at the front of so it might depend on what area of the small intestine and whether it's small intestine or large intestine, which is colon. So it's certainly a potential issue. I'll just stop there. Dylan asks, do I see nicotine as inherently more dangerous, harmful than ADHD meds? And why haven't they made a slow release nicotine pill? So I do have a video on nicotine for ADHD. There was a product under development for ADHD specifically, and it's not clear to me why it was abandoned. So I don't think nicotine inherently is more dangerous. What I think is that cigarette smoking, which has dozens of other carcinogens and other toxins that you are inhaling as smoke, is not good, and that many of the forms of chewing tobacco sources, you know, chewing is associated with mouth and esophageal cancers and tumors and other. So I'd say pure nicotine seems to avoid some of that risk and problem. So Dylan asked between bupropion and duloxetine, which do I prefer? So I've started, those were my two go-tos years ago when I was starting lots of people with ADHD. I'd say particularly if lots of anxiety, social or otherwise, is part of the picture, I would probably more often start with duloxetine. If that's less of an issue, then I'd be more likely to start with bupropion. Core focus, I've seen some people reports of ED and changes in urine flow, feeling more restricted while using Adderall and other ADHD stimulants. Is there research out there on this and ways to counteract? So most of the research suggests, so the two big neurochemical systems affecting bladder flow are acetylcholine, which affects how relaxed or contracted the bladder itself is, which can give rise to urinary symptoms, and norepinephrine, which controls the sphincters of the bladder and is also involved in sexual responsiveness. So it's usually thought to be too much noradrenergic, or that those neurons are more sensitive to it. So some of this, people can develop tolerance to that negative side effect and escape it with time. Um, Two, there can be more formal, and I would sort of body educational along the lines of CBT, of sort of retraining your body how to interpret signals. Again, this is more with the bladder urine than erectile dysfunction. Um, Three, with the erectile dysfunction, strangely enough, often have improving one part of your sexual responsiveness cycle. So strangely, Viagra, which we think only has to do with erection, can improve a whole range of function in terms of sexual functioning, in terms of delayed ejaculation, in terms of libido. So, so sometimes things that can improve other aspects of sexual functioning. So ginkgo biloba might be something to consider as a supplement. But a lot of it, I mean, there's a lot of feedback expectations both in our urinary system and our sexual response system. So very often, body training approaches can be helpful. Um, and good to mention that, exercise, sleep, hydration. I'm not as familiar with aspirin in that context. So what can I say about my findings, beliefs? And I'd say there's a lot of research on this, on comorbid substance abuse disorders. So a big topic, and I'll sort of blast through it quickly. In America, about 20% of people over the course of a lifetime develop alcohol or other substance use problems. That means these are really common. Maybe it's a sign of a sick society, but or just a built-in vulnerability to our brain. Having ADHD, most studies find, doubles your risk. You're more in the range of 30 to 40% over the course of your lifetime. There are data showing it's not just the impulsivity or hyperactivity, it's also, some studies have found that the inattentive aspects of ADHD also contribute. So you may be less paying attention when other people are warning about the dangers, or less likely to see what the friend who was misusing drugs trouble got into. So there's also evidence that children started before high school ages who have ADHD, if they take stimulant medications, that can lower their risk. And it doesn't eliminate the risk, but it puts it more back to the general population rate of 15 to 20%, which is cutting the risk for them in half, even though the stimulants themselves are potentially addictive medications and potentially addictive. The most negative of the studies I've found, and very few studies quantify the risk, suggest that maybe 2, 3, 4% of kids on stimulants and Adderall, amphetamine products do seem to have a higher rate than methylphenidate become addicted to that substance. So we're at risk of becoming addicted to that very substance, with the likelihood you will decrease addiction potential. Now, does that mean, again, there's still some people, these are drugs that cause them problems through addiction, and I'd say one other thing is that there's a few good studies done in different ways suggesting Vyvanse, a slow release prodrug form of amphetamine, can help people with a substance abuse problem stick with their program, remain abstinent from street drugs. So last time I asked about skin picking after my meds were off and my psychiatrist prescribed me fluoxetine. Now the skin picking is completely stopped. Does that mean I have ADHD plus OCD or autism? So I do have a video on repetitive, I keep blanking on the full term, body-oriented repetitive movements. So I'll sort of defer to that. So body-centered repetitive movements are their own category. They used to think it was part of OCD, but it seems distinct from OCD. I'll just say that. And that does not mean you have autism. Narendra, best roadmap for type 1 severe combined, the study shows serotonin, dopamine, acetylcholine. Yeah, so again, the biotype study, I think that's the one you're citing, what we're talking about here. The evidence, or the part they included with neurotransmitters, was more what they looked at was what other studies have found in terms of where neurotransmitters are concentrated and correlating areas that seem to be abnormally wired in each biotype with what neurotransmitters were prevalent there. So it's not a direct, okay, we've identified these type 1s versus type 2s, and looking at can now we've replicate or find that there are differences in these neurotransmitters. So I'd say at this level, it's at most slightly suggestive rather than indicating strongly which neurotransmitters are implicated causatively in each of these biotypes. That's where I would leave it. So thanks, Max, for the acetylcholine and ADHD link. So should Adderall improve mild depression? I mean, there are numerous studies, most of them older, that show Adderall and methylphenidate are effective as antidepressants. When they work for depression, they tend to do it quickly. And whether that's just part of the euphoric effect or whether it's a true separate antidepressant effect, I'd say there's conflicting opinions on that. So thanks so much for all the good questions. I will be going now. Thanks, Max, for providing quick links to the videos. There's one on nicotine, one on ADHD and substance abuse. And thank you all for being here. I'll be back at the same time next week. Stay healthy, stay happy, and try to stay sane in a not very sane world.